we go through the history of pain medicine and human rights development in general to talk about how the opioid epidemic grew. I am Mark Sullivan. I'm a professor of psychiatry and behavioral sciences, as well as anesthesiology and pain medicine, bioethics, and humanities at the University of Washington in Seattle.
I am Jane Ballantyne. I'm a professor of anesthesiology and pain medicine, also at the University of Washington in Seattle.
In this article, The Right to Pain Relief and its relation to the opioid epidemic, we try to delve beneath the usual greedy pharma narrative about why we had a terrible and continue to have a terrible opioid epidemic in the US, to what we consider to be the deep roots of this epidemic. And I would say they have two parts. One, a misunderstanding of opioids as targeted painkillers. Instead, they're broadly stress modulating and socialization promoting components of our endogenous pain system. And number two, we have tried to separate pain from the rest of human suffering as a uniquely medical, uniquely mechanical, and indeed innocent form of suffering for which it makes sense to claim a right to relief in the way that we don't claim a right to relief for other forms of suffering like loneliness or anxiety or depression.
I will just briefly describe what happened in terms of how we got to the point where opioids were popularized for the treatment of chronic pain. And it actually all began with palliative care and palliative care specialists who really did have to fight for the idea that people had a right to pain relief, because there were people dying in many places in the world, but including the United States, without the benefit of adequate pain treatment from opioids because of all the stigma of opioids and rules and regulations about opioids. So the palliative care specialists succeeded in introducing us to the idea that there was a right to pain relief, and that right included a right to receive opioids. And they also introduced and established the idea that treating pain as independent of other diseases, in other words, treating pain even if there was no underlying fundamental disease treatment, or that there was no cure as such, was something that should be part of medical practice. The problems began when the palliative care specialists took their ideas and extended them into the treatment of chronic pain. Their thinking was that if you could relieve people who were dying of the burden of pain at the end of life, then why not do the same thing for people with chronic pain? What they didn't realize, of course, is that a lifelong treatment with opioids is very different from short-term treatment with opioids, even if that short-term is a short-term period at the end of life.
We go through various different roots of the opioid epidemic, and at the end of the article, we talk about some remedies. And one of the remedies is to stop using the famous 0 to 10 pain intensity scale, which has become a lens through which we view the problem of pain, meaning that patients who now come to see physicians want their pain intensity reduced. They say, I have a 10 out of 10 pain and I want it to be 8 out of 10 or 6 out of 10. And pain intensity is only one dimension of pain. There's also its meaning, there's its extent, how much part, of the body is involved with it, how much functional impairments does it induce. The pain is a complex experience that we've boiled down to a pain intensity rating. And why is that important? It's important because nothing reduces pain intensity in the short term like opioids. And so by understanding pain in terms of this pain intensity measure, we have directed all of our attention to opioids. And we feel like this simplifies pain in a counterproductive way and perpetuates the opioid epidemic.
Chronic pain is not just a single thing. Chronic pain is incredibly complicated. And, we have a lot of debate about whether it's a disease or a symptom or, what exactly is it? Well, it's everything. It sometimes is a disease. It sometimes is simply a symptom that'll go away when you treat the underlying disease. And sometimes it's, a sort of impenetrable. We don't really understand what it is, but we know it's there. And part of the consequence of that, complexity is that not all chronic pain is suitable for medical treatment. And we tend to boil it down to, if you have pain, then you go to a doctor and the doctor will, do everything they can to take the pain away. But quite often the doctor has limited tools. What the doctor can do in many cases is involve the patient in their own care or in self-management. And, one of the things that's gone wrong with the idea of the right to pain relief, and particularly the right to opioids, is this idea that doctors have solutions up their sleeves and they can take all pain away. And that's, we argue, has disenfranchised patients from a lot of things they can do to improve pain, even without medical intervention, particularly without pills or injections or operations.
You hear a lot of discussion of undertreatment of pain and overtreatment of pain, overprescribing of opioids, underprescribing of opioids, but people never define those terms because they're actually quite hard to define. Opioid prescribing is quite a bit down in the US from what it was a decade ago, but it's still much higher than what it was in 1999, and it's still much higher than in any other developed country. So are we over or under prescribing opioids at this point? Our argument is that you have to think a little bit more deeply about when pain needs medical treatment, when it needs opioid treatment, to try to sort through this to find out what the proper level of treatment is. And it cannot be determined simply by a pain intensity score. We have to understand the downside of pain treatment, its impacts on thinking, function, addiction, etc., as well as the upside, which is some of the complexity that Dr. Ballantyne has been pointing to. We do review a lot of this in our article in Mayo Clinic Proceedings that's going to be coming out in August. We actually review it even at greater length in a book that we just recently published with Oxford University Press, titled The Right to Pain Relief and Other Deep Roots of the Opioid Epidemic. And as Jane hinted, this is putting greater prominence on non-opioid pharmacology, greater prominence to self-management and behavioral treatments that don't have all of the downsides that we have seen with the opioid epidemic.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.